right, everyone. It sounds like Dr. Frank wants me to just go ahead and get started while she figures out the audio issue on her end. So let me play from the beginning. Um, like she said, I'm a first-year adult congenital heart disease fellow here at Baylor, kind of splitting time between the adult hospital at St. Luke's and Texas Children's Hospital. So I'm enjoying spending a lot of my elective time doing some cardiac MRI, and we're going to focus on a few of the interesting cases we've seen over the past month or two. So without further ado, here's case one, and I've deliberately been a little bit thin on the history so we can go through images and video clips. But this is essentially a 67-year-old man who had prior history of surgical aortic valve replacement with concomitant CABG for CAD due to significant triple vessel CAD seen on his pre-op workup. And he basically showed up to an outside ER with TIA-like symptoms and then was referred to us based on abnormal echo findings. So here are a few still frames. I'll stay on this for a few seconds. And we'll play some clips. Basically, first picture or first video clip will go in order, just going through stacks. Second one will be rest perfusion imaging. Third one will be LGE. Okay, so what does everyone think about these? Anyone want to chime in on what we're seeing here? Okay, so this is basically, can everyone hear me, by the way? It sounds like y'all could hear earlier, but I'm not sure.
Yes, I can hear you now.
I can also hear you.
Were you able to hear earlier?
Yes.
Okay. All right, cool. Sounds good. So yeah, so this case is basically demonstrating a large inferior pseudoaneurysm with a pretty obvious large thrombus adherent to the wall of said pseudoaneurysm. And basically, when we asked this patient some further history, he reported that while his surgical AV valve replacement and CABG had been several years ago, only within the past few months or year, he was diagnosed with the missed inferior STEMI. Interestingly enough, he said he had severe chest pain while playing golf, decided to ignore it, not go to the ER. Subsequently, he eventually saw a cardiologist and was found on EKG to have basically had a completed STEMI. So this is a very classic mechanical complication of a missed STEMI that was not reperfused, and this was correlating with his known inferior territory. So you can see this large sac basically, and so these stack images basically showed this whole aneurysmal portion bulging out of the inferior wall. On the perfusion imaging, we can see that basically there's no contrast uptake in that segment of the myocardium. And in the LGE images, you can also see that there is transmural late enhancement throughout the sac and the inferior wall, again, confirming what we suspected, which is a total transmural ischemic scar without any viability, which checks out for an unreperfused STEMI. So interestingly, we were able, upon doing volumes on the study, to calculate exactly how much blood was just swirling in that stack and causing his thrombus. So there was 57 cc's of blood that was adding to his end diastolic volumes, but not adding to his end systolic because there was complete akinesis of that segment and it was not contracting out. So ultimately, this patient underwent surgical repair and he's currently still in the hospital. So not going to be taking too much time with like the didactic portions, but like I mentioned earlier, pseudoaneurysm is a very classic mechanical complication of an unreperfused STEMI. The other classic mechanical sequelae can include papillary muscle ruptures with acute MR, VSD, free wall rupture. The first three tend to be very acute and dramatic in presentation with rapid onset hemodynamic instability, whereas a pseudoaneurysm may be missed and as it takes several weeks to develop, but it can be picked up by persistent ST elevations in the affected segment and can cause VT and sudden death. So generally it does need to be repaired even if it does not present acutely, which is why this patient did end up undergoing surgery. Okay, case 2. So this is a 63-year-old man with unspecified developmental delay, not much other information on him in the chart, but he has had some hospitalizations for decompensated heart failure requiring IV diuresis. He underwent echo at an outside hospital. Don't have the full report, but there are some snippets of cardiology notes documenting that he has cardiomegaly and an unspecified leaky valve. So he was referred to us for CMR for further evaluation. All right. Oh, someone's saying there is no. Which user can't hear me? I have to go back and check the messages.
I can hear you.
You can hear? Okay. All right. I'm not sure who just put in the chat that they can't a couple minutes ago. Okay. All right. So moving on, let me play these videos. So here we just have an anatomical 4-chamber assessment. Okay. Here we've got Q flows covering roughly the same area. Okay, we'll play those again, let y'all take a look and see what you think.
Is there an ASD?
Okay. Where do you think the ASD is located? What part of the intratracheal septum? Or I guess I should say, what
Looks
kind
like
of
it.
ASD do you think this is?
I think you're trying to show a primum.
Okay, awesome. Yeah, well, you would be correct about that, so good catch. It's not the easiest image, but right here you can see right above the mitral and tricuspid valve annular plate, basically, you can see this defect, which is definitive of an ostium primum ASD as opposed to an ostium secundum, which will typically be right in the middle of the interatrial septal wall. And this phasic flow image kind of redemonstrates that. As we wait for it to play, you can kind of see the shunting flowing across that defect in the same plane.
And can I ask, were there valve images to know like that the mitral and tricuspid valves were normal in morphology?
Great question, and I'm going to address that on the next slide.
Oh.
Unfortunately, we didn't have great valve images on this patient because they really couldn't lay flat and tolerate breathing and breath holding for the study, so it was a free breathing acquisition. But that's an important question, which we're going to talk about why. Okay. And here's our QPQS, which is pretty significant as far as calculated shunt flow. Pretty, yeah. All right, so yes, you nailed it. So ostium primum ASD with concomitant severe mitral regurgitation. Now, as I mentioned, we really did not get great valve images. I would have loved to see that mitral valve more in short axis to rule out cleft or anything, but we were able to calculate significant mitral regurgitation with a regurgitant fraction of 81% just by volumetric analysis. And other features that you'll notice on these clips and images is obviously you have significant dilation of the right-sided heart structure, specifically largely dilated IV with RV with systolic dysfunction, and that is due to left to right shunting across the ASD with resulting right-sided pressure and volume overload. Now, as far as the valves go, it's not that common for an ostium primum to occur in isolation as opposed to an ostium secundum. And ostium primum ASD is considered on the spectrum of AV canal defects or AV septal defects, which are basically a form of endocardial cushion defects. And so a primum ASD is very frequently associated with a cleft mitral valve that over time, especially by middle age, can become severely regurgitant. So that is definitely something you would want to assess in the study. And it's something we were able to indirectly assess via volumetric analysis, but unfortunately we couldn't get great images of the valve proper. So just to talk briefly about ASDs and AVSD subtypes, secundum defect is by far the most common type of atrial septal defects. And like I mentioned earlier, this occurs kind of like right smack in the middle of the intraatrial septal wall, making up over 3/4 of ASDs. Primum is second most common, occurring just above the junction of the atrial ventricles at the valve level, making up about 15-20% of ASDs. And sinus venosus defect, is not really a true ASD per se, but rather a defect in the wall separating the vena cava from the pulmonary veins. So it functionally results in the same thing, but the defect is not truly in the atrial wall itself, although you can argue that it's usually at the confluence between the venous inflow and the atrium. And so here, like I mentioned, a primum ASD is on the spectrum of endocardial cushion defects or AV canal defects. So on the most extreme end, you have a complete AV canal defect in which you basically have one giant continuous cavity of the heart with like this free-floating single atrioventricular valve and free flow between the common atrium and the common ventricle. You can have an intermediate or transitional version where it's a so-called unbalanced defect where one ventricle is, the defect favors one ventricle size at the expense of the other, and the valves are kind of asymmetric. Now, when you get to transitional and partial, these are generally less severe, with the reason being in a full-on canal defect, since there's one common AV valve or two valves that are attached in the same plane, that's abnormal. Whereas in a normal heart, the mitral valve and tricuspid valves are in slightly different planes, with the tricuspid being slightly apically displaced. So in a partial defect, which is the most I guess, benign variant, you have your primum defect right above the valve level. The valves are still in slightly different planes. You don't have much of a VSD, if any, but you might still have this abnormal cleft in the mitral valve, which is reflective of that abnormal development. So clinical sequelae of this are all kind of the same for the various types of ASDs. You have chronic left to right shunting, develop right-sided dilation dysfunction. In the long run, can result in pulmonary hypertension. Fun fact is that you can tell the difference between a secundum and primum defect just by EKG, because all ASDs will have a right bundle branch block, but the axis deviation will tell you the location of the defect. A complete septal defect is a very classic finding in trisomy 21 or Down syndrome, although Down syndrome patients can have partial or transitional AVSDs as well. We don't really have great data on this patient's background, but given his history of developmental delay, I wouldn't be surprised if he turned out to be a trisomy 21 or at least a mosaic or something of that sort. Another feature that goes along with this is the so-called gooseneck deformity of the LV outflow tract due to the anterior displacement of the atrioventricular valve plate, which kind of impinges on the LVOT and can lead to subaortic stenosis. So that, in addition to valves, is another thing that you will want to look at when imaging these patients. And last point is a bit beyond the scope of this talk, but balanced versus unbalanced basically defines whether the patient will just be able to get routine ASD and VSD patch repair, maybe a valve repair, or if they will have to go down the single ventricle repair pathway in early childhood. Okay. So quickly, just these are ACC-AHA recommendations for intervention. The most important thing to remember is any symptoms that are ascribable to significant right-sided, left to right shunting with the clinically significant QPQS of over 1.5 to 1, and provided that you don't have massively increased PA pressures at the expense of systemic pressures would be an indication for closure, whether surgical or percutaneous. Okay, any questions on case 2?
So I mean that's terrific. That's great. So let's try to maybe involve people as well. So maybe this case 3, it's really neat and nice case. So maybe someone could look at it and tell us what they think to make it a little interactive. What do you think?
Yeah, totally.
All right.
I don't know if your audio was back at that time, Dr. Frank, but someone did answer and caught the primum ASD.
It's just okay. That's wonderful.
Yeah.
That's great. Yeah. Okay, keep going.
Okay. So I will play these clips and stay silent. Okay. This is incomplete information, but what are we seeing so far?
I mean, we're seeing regurgitant jet, but it's higher than the annular plane. It's kind of weird.
Okay. So we're seeing a lot of AI. Yeah. Okay. Shoot.
Quadricuspid.
Quadricuspid. Sorry, I didn't mean to bring up the spoilers.
That's so cool. I only, for the first time in my career, finally saw one of these a few weeks ago, and so now this is like in the wild. So fun.
I love it. I think this might be I think this is potentially the first or second I've ever seen. I think I might have seen one in general cardiology fellowship a couple of years ago, but I don't think it was even my patient. I think it was someone else's patient. But yes, quadruped aortic valve. Note the additional small hypoplastic cusp between the left and right coronary cusps. And of course, there is associated leaflet degeneration and severe regurgitation. Well, I guess by flow calculation, we're in the more moderate-ish range with AR calculated at 33%, but it's kind of getting, up into the borderline moderate to severe range. So yeah, quadricuspid aortic valve. So we can clearly see the regurgitant jet in these images. There is no cross section here, so there's no way to easily tell in these long axes that it's a quadricuspid valve, but nonetheless you can see that the jet is somewhat eccentric, not like the central, especially in this view, it's not your typical like central jet that you expect from a traditional leaky tricuspid valve with the very central coaptation defect. And this is just a great picture in short axis showing the 3 leaflets and the 4th baby leaflet. So quadricuspid valve is a very rare aortic valve anomaly, actually the rarest one. So obviously we have the standard tricuspid valve. The most common type of aortic valve congenital abnormality is bicuspid valve. And as a matter of fact, I believe bicuspid aortic valve is the most common form of congenital heart disease in the adult population. And that's a popular test question because if you'll ask most common type of congenital heart disease, you might think VSD, but that's only if you include peds population. I think in the adult world, the most common variant is a bicuspid aortic valve. Then you can also have a unicuspid aortic valve, which is also super rare, and then quadricuspid. So whereas a bicuspid aortic valve can obviously cause either stenosis or regurgitation, the quadricuspid valve tends to present more of a regurgitant phenotype. And there's kind of a wide spectrum in the quadricuspid phenotype where you can have like a true 4-leaf clover kind of appearance with like a central coaptation defect and equally sized cusps, or you can have several variants where you have imbalance in cusp sizes. So equal cusp is type A, type B you have 3 normal cusps with a smaller one like in this patient. And that is more likely to have significant or at least clinically significant regurgitation due to asymmetry and asymmetric stress of blood flow. And to not belabor the point, these frequently can be associated with other cardiac abnormalities as well. Excuse me. So kind of repeating what was on the prior slide, we have this graphic kind of showing the various classifications of quadricuspid aortic valves and all the variants that you might see. Excuse me. I'm trying to not have a coughing fit. So as you can see, the supernumerary cusp can basically appear between any of the other 3 anatomically normal cusps. Okay. Any other questions or comments?
Yeah, sorry, I can't remember if you mentioned it or not. Are there any like highly associated anomalies or features with the quadricuspid?
Highly associated anomalies or features? Honestly, not to my knowledge. Like,
Hmm.
as we have on the slide, these are some of the additional cardiac anomalies that can go with quadricuspid valves,
Yeah.
like, VSDs, PDAs, subaortic
Okay.
stenosis, etc. I think the one that I've heard of the most is actually a nonspecific cardiomyopathy, which is not very well understood. And it's possible that it's kind of like a subaortic inherent myopathy that kind of goes along with just the structural defects that might have resulted in the valvular malformation, but I don't really know in detail. It's not something like bicuspid valve where you have very clear syndromic associations like a thoracic aortic aneurysm and Turner syndrome and coarc and all those things.
Yeah, exactly. That's why I was wondering.
Yeah.
Perfect. Thank you.
Yeah. I am not aware if there are specific gene mutations associated with quadricuspid valves like there are with bicuspids, but there probably are, and I just don't know the names. Okay. So case 4, this is a 50-year-old lady with severe tricuspid regurgitation. And I'm deliberately not giving any more information except that she has severe tricuspid regurgitation. All right. Let me play
Yeah, I
these.
believe we didn't even have that much of an information on her. She's from somewhere overseas, I
Yeah.
believe, and the information was really limited.
Yeah, to be fair, we didn't have any information anyway. I mean, there was an echo, which is really the only additional source of information that we're skipping. But like, I couldn't even find in the chart why she got an echo, because all of her notes in our system were about like GI bleed. So kind of confusing. We have very few records. She had a lot of her stuff done outside.
Right, let's play. And then in these particular cases, it's a good idea to have this discussion about, well, why would this right heart be that dilated? Why would there be a severe tricuspid regurgitation? And then have this discussion about the differential diagnosis or suggested diagnosis in these particular cases. So if someone wants to elaborate a little on what we are seeing here and just to have this discussion started.
Well, while the short axis scrolls through itself, at least on the four chamber view, like you see the right heart, the right atrium, the right ventricle are dilated. They're asymmetric compared to the left heart chambers. Um, I can't remember like if it was hypo functioning or not, but anyway,
I'll play it again when we
whenever,
get, we're on through the short.
yeah,
Yeah.
what is it?
Oh, I said I'll play that clip again once the
Oh,
short
okay.
finishes playing.
But yeah, regardless, whenever I love talking about right heart dilation with residents all the time because it is a differential, right? Like, is there too much volume going there? So you think about a shunt somewhere, like, is there a partial anomalous pulmonary venous return or a shunt somewhere else in the body? Is there pulmonary hypertension? In this case, since the left heart doesn't look big, and again, I can't remember if there's any MR, but I didn't see anything floridly to think that there's, left heart dysfunction. And then on the short axis, at least at the level of the pulmonary vasculature we see right now, they don't look dilated. It's smaller than the adjacent aorta, so I think that's fine. And then things like that go along with too much volume. Is there regurgitation happening that's keeping volume on the right side? Um, and then the other thing I would think is there's something abnormal with the right ventricle to begin with. Like, are we considering, an ARVD or ARVC kind of picture? And so I would need to just keep looking at all the images to start teasing that out. I am wondering if that septal leaflet of the tricuspid valve is a little lower than than we see laterally. So is this an Epstein anomaly kind of situation? I would want to keep watching that and actually get a measurement there. There's some tricuspid regurgitation, so could look in the short axis plane to see if the leaflets are coapting well. Anyway.
Yeah, so all of that is super great and a great differential. So totally agree. So we can all see that the right-sided structures, the RV and RA, are both massively dilated at the expense of the left side, which is kind of squished, but overall, normally functioning, not significantly hypertrophic. The right ventricle myocardium does appear rather tuberculated, more so than usual. We can see that the atrium in particular is huge, and yeah, so as far as the right-sided differential, definitely would always think of shunting when seeing a huge right-sided, dilation like this. And again, the tricuspid leaflet is a good catch because when you see a more apically displaced tricuspid valve in the setting of severe right-sided dilation and failure, you're always going to want to think of an Epstein's anomaly. So those are
Let's go to
all
the
really important
yeah.
differentials.
Let's go to the next slide because so that's along these lines that Jonathan mentioned. Yeah, maybe a little. I don't know if this is big enough for you guys to see. We wanted to give you an overview of everything that's going on, but then also on the next slide, to make sure that we're not talking about the shunt that is not visible currently on these particular ones. So the QPQS was normal, so there was no left to right shunt. So this is not, and that would be a massive shunt actually if we were talking about shunt to lead to such a massive enlargement of the right cardiac chambers, right? All right. Sorry, keep going.
Oh, you're good. I'll go back and play this one more time. But yeah, so, just based on the images, we came up with this differential. And now in the next slide, you can see that our QPQS is normal. So that pretty much rules out the left to right shunt, the differential diagnosis. So yeah.
Oh, yay.
Yeah.
You passed, Jonathan, we passed.
Before you start talking about this, I will ask you guys, and especially like Luba, I feel like we see these so often, just I don't want to say incidentally, but like they're picked up in newly pregnant patients with shortness of breath, and then suddenly they just randomly have Epstein anomaly on echo, and then we get a cardiac MR. Like,
And you're right. And actually, it was a little bit hard for me to. We've been staring at those images, and measuring that distance, and the distance was clearly off. So that was clear Epstein anomaly on this
yeah,
particular one. But when there is a really markedly dilated right ventricle, so those changes happen, and sometimes it's really hard to tell if that actually an anomaly or this is because of some secondary the abnormality, as you said, pulmonary hypertension. It could be idiopathic pulmonary hypertension. It could
yeah,
be shunting. It could be anything. So this is not an easy diagnosis to begin with, even though some people think, oh, that's easy. So you really need to look at this septal leaflet, because sometimes what you see actually the septal leaflet is really displaced, and then the lateral is not that much, and then the short axis helps a lot as well, because when you see it's a little appropriately done short axis, right? So when you see that the different levels of the valves, then you can clearly see that tricuspid is more caudally or toward the displaced toward the
yeah,
apex, and that's like off plane when you compare it with the mitral valve.
yeah,
So, but obviously, Amina is probably seeing those more than I would do, because we're dealing with adults only, and I think that Amina, you're rotating with peds as well. So I don't know how often do you see that in children.
Oh, I
Um,
don't deal with peds. I only deal with adults. But we're like physically based out of Children's Hospital, so we pretty much get everyone who turns 18 and graduates to us. So it's
yeah,
certainly a
yeah, but do you feel that
yeah,
you also see that pretty often, or?
we've it's not the most often, but we've definitely had a few, including an interesting patient quite recently on our service with like some diverse presentations. Um, so yeah, that's actually an important point to make, just picking these up in the wild, because there's such a huge degree of variation in how they present. Like some people, have been diagnosed in their 70s, just incidentally they get an echo, they have like
yeah,
right-sided heart failure symptoms, and it's like, okay, you're 70, you've been smoking your whole life, you have COPD, you probably have, WHO group 3 pH from lung disease, and they echo them, and it's like, oh, wait. So that is, one end of the spectrum. And then in the other end of the spectrum, you can have such a severe Epstein's variant that it's essentially like a hypoplastic right heart. And these kids are blue at birth and need surgical repair and sometimes even a single ventricle palliation with the Glenn and Fontan. So
yeah.
it
I know,
can
and I
You
feel
mean
like
that
it's
this?
maybe it's kind of skewed because like they're coming to us with a cardiac anomaly, so it's like
right.
sub-selected population.
Yeah. Sorry, Dr. Frank, we're going to say something.
Oh no, I was when you say that the hypoplastic heart, you mean the hypoplastic right ventricle, right, with a huge
Yes.
right atrium and
Yeah.
all those, yeah, yeah, definitely we've seen those too, but that is
Not
not an
common.
easy, yeah, sometimes not an easy diagnosis to
That's
make.
what my most recent patient had, but it's certainly not the most common variant. But yeah, the definition, as everyone here knows, the tricuspid valve is a bit more apically displaced compared to the mitral valve. They're not in the same plane, except in the case of AV canal defects, as we discussed with case one. But to diagnose an Epstein's anomaly, you need to be beyond what's considered the realm of normal degree of apical displacement, which is typically more than 8 millimeters per meter squared when indexed to BSA. And so the valve displacement really demonstrates more of an atrial myopathy or ventricular myopathy more than just a valve problem. And so there's failed delamination in embryologic life of the tricuspid valve leaflets, which means they kind of fail to peel off the surrounding myocardium when they're forming. So only the anterior leaflet is the one that's attached to the true annulus, and that's why it's like big and floppy and the buzzword is sail-like, whereas the septal and posterior leaflets originate off the actual wall further down. Um, and so that is what results in the quote unquote atrialized portion of the right ventricle, which is that portion that should technically be ventricle because it's after the normally located valvular annulus, but is basically atrial muscle because the posterior and septal leaflets are not there, completing the separation of the chambers. So you can have relatively mild variant, or you can have so much atrialized right ventricle that there is effectively no functioning right ventricle whatsoever. And that's why these patients in the more extreme form can essentially have no RV output whatsoever and just have to be reliant on a Glenn-Fontaine circulation. So this kind of says the same thing. So here is demonstration of atrialization where you've got your, valve annulus in the normal place, but everything is basically atrial style type muscle until posterior. And so this is really your functional RV, which we've also had some issues, dealing with our most recent patient who has essentially failed Epstein's anomaly repair, who had to progress to Fontan, who at this point is a failing Fontan and is now undergoing workup for transplant. There's this argument going back and forth. Well, she's only 32. Should we actually transplant her right away and then basically commit her to, needing retransplant in maybe 10 to 15 years at best? Or does she have any salvageable cardiac output from whatever is left of her RV that we could just revise the Fontan and, preserve some contractile function and kind of kick that can down the road? And so there was some back and forth based on her MRI and how her volumetric analysis was done. Were they actually including part of her atrialized RV in the calculations, and is she truly a pulsatile Glenn, and all this wild stuff. But yeah,
That is like the biggest, I won't phrase this, that's the most difficult part. That's how I'll phrase it for
yeah,
these cases, I think, is coming to a consensus on the volumes.
right.
I will ask, with how subtle the case was that you showed, how easy was it to contour the volumes, or did you really wind up separating out the contours?
We just eyeballed it. No,
Yeah.
no, I'm joking.
Thank you, Lupa. That was what I would have done.
Yeah.
Well, it was a little bit easier, right? So I think that it's
Yeah.
more difficult to, and I'm sorry to pitch in, I mean, but it was more difficult would be more difficult to contour something like this. This is actually an older case
Yeah.
that I mean, is showing now. This is older case that I had at TTMB actually. So I love showing this one because it's just so characteristic, and there's no one would have any doubts about the diagnosis in this particular one, right? But
Yeah.
the ones that we showed, and specifically that's why we wanted to show this case, that it is difficult. But you do have the contour of the oral level of the leaflets, and it is more difficult, but it's okay. But surprisingly, we came up with the volumes with okay volumes, and we came up with the volumes that were matching the stroke volumes as well. So it was okay. But yeah, it takes some time to do. It depends on what software you're using too. I don't know, what software are you using?
I like circles.
Yeah, circle. Yeah, we did too. I think we have one more case to show, right, Amina?
Yeah, we have one more.
Yeah. Unless there are more questions.
No, I think we're pretty much done with this one. We had so this slide, I'm not going to belabor the point because we already talked about it, but these are the summary of MRI findings in Epstein's anomaly. And I just threw in this extra slide in here, which is again from the ACC-AHA consensus document on adult congenital heart disease patients. So this document kind of provides for every type of ACHD imaginable what testing you should do at what intervals. And for Epstein's, which counts as at least moderate congenital heart disease and severe in its most extreme form, but moderate to severe depending on the patient. For most moderate ACHD phenotypes, the guidelines do recommend intermittent cardiac MRI in lieu of annual surveillance echo once every several years. with the frequency becoming more closely spaced as the patient's clinical condition deteriorates. So that's just one thing I wanted to throw in there.
Right, and then just a little note as well. So I don't know how many of you, when you think that this is an Epstein anomaly, how many of you actually report that it is 8 millimeter, more than 8 millimeter a square. So this is like that it's a referenced value, because we used to kind of just measure the distance, but really just pay attention to those guidelines and to those specifics. That it is better to it is better to calculate the reference value, because of the patients are different, the PSA is different, etc. So on. So that's why we put it beyond 1 centimeter or beyond 8 millimeter to BSA. Okay.
Alrighty. Oh, well.
Oh, it's already. Oh my God. Okay. All right.
Oh,
We gave it away.
no.
I honestly didn't even notice it, but I was going to say amyloid just because of the plural effusions.
I forgot. I didn't make the slide, but I forgot to delete it. It was there. I think
That's
it was
okay.
Yeah, actually, I sent you the updated one, but that's okay. That's okay. But okay, so is there anyone else that could just talk about this, or we just really quick show and tell? Really wanted to show that case because it's such a classic case, such a beautiful case, and it's just really, if someone is taking boards, and we could have it real quick reviews that would be able to, would be informative and. Or anyone, I believe, especially someone who's taking boards. All right, then it's a show and tell, I guess.
Okay. Yeah, so let me scroll through what we've got here. Okay. So, I mean, yes, so going back to this original clip, definitely very prominent bilateral pleural effusions. We can see here as it plays through that you do have quite significant concentric left ventricular hypertrophy and significant biatrial enlargement, which is all quite typical of cardiac amyloidosis. Ejection fraction doesn't look too bad, which is pretty normal early in the course of the disease. You have more of a heart failure with preserved ejection fraction picture. Both atria tend to be quite large, but in this particular case, the right atrium is super large from elevated pulmonary pressures from chronic diastolic dysfunction. And the short axis more or less shows the same thing, again, re-demonstrating the concentric LV hypertrophy. So T1 map analysis results, that's another important finding in cardiac amyloidosis. So as you can see, the native T1 time is quite prolonged at nearly 1300 milliseconds. And I don't, let's see if they say by segment, but generally on global longitudinal strain by echo of amyloidosis, which is something that kind of correlates, I think, with T1 findings on MRI as well, you tend to have apical sparing, which in GLS is called a cherry on top pattern. So you tend to have increased infiltration or increased fibrosis in the basal and mid segments of the LV wall, and less so at the apex. And so for cardiac amyloid, the increased native T1 generally is reflective of fibrosis, as we all know, and that kind of correlates with degree of infiltrative disease.
Well, this particular, can you go back? So in this particular case, the ECV, if you can look at the ECV, was about 70. That's really, really abnormal.
Yeah.
So, yeah.
And that also tends to be enlarged as well. I forgot to mention that part. Yeah.
Right.
Okay. Let's see.
This is a long TI. This is a 600. So we do the long TI pretty much on almost every single case, but it's just so characteristic for lack of contrast between the blood pool and the myocardium, and in the very early early post-gadolinium enhancement in the high TI. So this is just really striking. And that's why I just wanted to put it in and show it to you. And then we're going to go into the delays. There you go.
Oh, yeah, these are just still snot clips. Yeah. So here's our delayed gadolinium enhancement imaging. So this is, again, very typical of amyloidosis, where you basically have this kind of diffuse circumferential subendocardial LGE, which kind of geographically reflects the amyloid deposition and fibrosis throughout the entire LV and even RV walls. And the other thing that can happen is you notice this in the atrial walls as well, which is not super common in other conditions. Okay. Any other questions or feedback on the images before we do the amyloidosis talking section? Okay. So cardiac amyloidosis is basically an infiltrative disease characterized by extracellular deposition of proteins in various organ walls, which obviously can include the heart if we're talking about cardiac amyloidosis. So amyloid is just a super vague umbrella term. So if anyone wants to have traumatic flashbacks to like basic science in undergrad, we have, the alpha folding of proteins and then subsequent folding into beta sheets, and those can deposit in a variety of different clinical conditions. But the two types of depositions that can occur in the heart are either light chain proteins in the case of AL, cardiac amyloidosis, which pretty much results always from plasma cell dyscrasia, which is essentially a hematologic malignancy, or you can have deposition of amyloid transthyretin, which is essentially a hepatically synthesized protein that is intended to transport thyroid hormone precursors, but due to a mutation results in protein misfolding and becoming prone to deposition. And this can be divided as well into the wild type and the heritable form, with the wild type being more common in the elderly and generally having less multi-systemic organ involvement. They will look the same for the most part on imaging. They essentially can cause an infiltrative and restrictive cardiomyopathy. You'll develop a type of diastolic heart failure picture. It can look like a phenocopy of hypertrophic cardiomyopathy in the sense that you can get very, very severe concentric LVH with at least initially normal ejection fraction and subsequent biatrial dilation. In the later course of the disease, you can get burnt out amyloid where the ejection fraction drops and you develop systolic dysfunction on top of diastolic dysfunction. And for systemic amyloidosis patients, which are mostly ALs, cardiac amyloidosis is the leading cause of mortality. So we kind of went over this. So kind of clinical gestalt that you might see: LVH, diastolic dysfunction, atrial fibrillation is very common. Another thing that is quite common is unexplained mild troponin elevations without any obvious signs of ACS or typical angina. Now, these are some of the associations that tend to occur with more like non well, so in like the senescent type of amyloidosis, it's pretty common to have all these vague issues like carpal tunnel syndrome, spinal canal stenosis, rotator cuff tear, etc. You can have GI symptoms from GI infiltration. Macroglossia and black eyes are another like classic textbook finding, but much less common. As far as the amyloidosis diagnostic algorithm, so, it's important to be kind of clinically aware of what to look for because, like I mentioned earlier, at least especially in the earlier phases, this can just look like any concentric LV hypertrophy. So is it hypertrophic cardiomyopathy? Is it just, long-standing uncontrolled hypertension? And most amyloid cases are in middle-aged to older people who often have comorbid hypertension. So a lot of them get missed because it's just chalked up to that, because it really can look very similar, especially in patients who develop renal dysfunction as a sequela. Starry sky appearance on echo should tip you off, as well as massive biatrial enlargement. But again, these are not, pathognomonic by any means. So it's important to take a really good history as far as other organ dysfunctions and any B symptoms things like that would make you potentially suspect a hematologic malignancy if you're considering AL amyloidosis also. So as far as the diagnostic algorithm, if you have suspicion for cardiac amyloidosis based on history and exam, the first thing you need to do is serum testing, with actual kappa lambda light chains to rule out the presence of the monoclonal protein. And if you have that, you pretty much know it's AL amyloidosis. Now, if you don't have monoclonal protein, you can proceed to a PRIP scan, which if positive typically defines the ATTR variant. But I think the algorithm we learn is a bit confusing in the sense that it doesn't mandatorily include CMR in it, but CMR is a pretty important stage in workup for either type, which is evidenced by this algorithm here. So like,
and then, Amina, we had, so I'm sorry to cut you, but we had a grand round speaker actually presenting one of the, was speaking about amyloidosis. And then he specifically, I asked the question about MRI because MRI was not really highlighted in his talk. And then he said, well, we're not that lucky as you are to have MRI readily available. So that's part of it.
yeah.
So not everywhere MRI is available for routine diagnosis of amyloidosis. So that's probably one of the reasons.
Okay, that makes sense. But as far as cardiac MRI findings, we kind of talked about the classic ones. So global sub-endocardiology E, dark blood pool, expected elevated native T1 and DCV, representative of kind of your infiltrative and eventually restrictive cardiomyopathy. And ultimately, if you still can't get a definitive answer from imaging, tissue biopsy is always an option. Typically, you don't need to progress to endomyocardial biopsy. That's pretty rare. Generally, more accessible organs will give you positive testing. And this is an example of that apical sparing pattern I mentioned earlier. Okay, so yeah, again, just to retouch on the MRI features that we already discussed, obviously LVH, circumferential LGE, atrial LGE is a big one, high TI, high ACV. And I think that
Yeah,
is
this is a famous one. So that's a famous graphics, right? So that shows that the T1, how important the native T1, the values of a native T1, they're far above any other diseases that would show elevated T1 and native T1 times and ECV. So that is just, it stands when we're talking about really truly a case of amyloidosis, that's going to help a lot. So that's just very representative and being shown actually at every meeting, but just to reinforce that knowledge and make sure that you guys do use the mapping or multi-parametric assessment in these cases.
Okay, but if no one has other questions, I think that's it.
Wow.
Wonderful cases. Thank you both.
Thank you.
Well, thank you for being here. So if we're still here, if anyone wants to ask, happy to discuss, or you can always send an email and have a discussion offline as well. Always happy to help.